Hello, everybody. It's Peter Beresford here, welcoming everybody to this third webinar organised in association with Policy Press, to whom thanks, which is focusing today where our major focus has been participation, and we've been looking at social policy and disability, and today we're looking at what people call mental health. And we've got a terrific panel here today. And people will just wave first, so I'll introduce them properly when they're speaking. Colin King, Reima Ana Maglajlic, Amander Wellings, Danny Taggart, and Sarah Carr. And we've got some great support from Jess Miles. And I'll very briefly introduce the session, but Jess will start us off, if that's okay, by just giving us some kind of webinar housekeeping advice and guidance. Over to Jess.
Yeah, thank you, Peter. My name is Jess Miles. I'm from Policy Press. Just a few housekeeping things. There'll be a Q&A session after all the panelists have spoken. So if you have questions, we hope you do, please type them into the Q&A function at the bottom of your screen and not the chat. And then Peter will put the questions to them in the second half of the session. We have the raise hands function on. If you do raise your hand, I'll get in touch and I'll message you for comments and questions. If you have any technical issues, please use the chat. We have closed captions enabled on this webinar. So there's a button at the bottom of your screen. I think it says CC live transcript. So please use this to show or hide the text as you prefer. We'll be giving details of how to order Peter's books published by Policy Press at a 50% discount. None of the other panelists are Policy Press authors yet, but I hope they may be in the future. So I'll pop a code to get a discount on Peter's books in the chat as well. And lastly, a recording of the webinar will be available afterwards, and we'll email you in the next few days to send you the link when that's available. Thank you, and thank you very much for joining the webinar today.
Thanks, Jess. And I just should say that Sarah is a co-editor of one of your books, and we mustn't forget that.
Thank you, Peter.
So I'm going to very briefly introduce the session, if I can, by saying that mental health policy and practice is an area where involvement has long been struggled for, but the psychiatric system has shown itself amazingly adept at resisting change. The changes service users and our organisations have sought have often been tokenised and incorporated into existing arrangements rather than transforming them. This is an area of policy where the pressures now are particularly bad, both nationally and I'd suggest internationally. It's underfunded, wrongly directed, controlling, based on force and compulsion, now into the community as well as in institutions, and heavily discriminatory. There seems to be a worrying informal alliance with neoliberal politics, the ideology that's resulted in the dominance of the for-profit market and the reduction of support services, and also with Big Pharma with an over-reliance on drug rather than talking treatments, despite the inadequacy and problematic nature of this approach well documented. The system is still largely based on old ideas, old assumptions and treatment approaches, notably individualizing problems, pulling more and more people into the net of the psych system, young and old, with an ever-expanding, more powerful psych system. Looking internationally, even more worrying, looking beyond the West to global South and middle and low income countries, where the psych system has sought to globalize its intervention. We need to see the decolonialization of knowledge, of treatment approaches, and challenging the ambition of global mental health, meaning the psychiatrization of distress everywhere. We need to hear what service users and our organizations have to say and offer. We're seeing that with the emergence of mad studies to some extent. There's a new potential for the positive, but it's also got potential limitations through over-academicization and being narrowly based. We must build on the insights that highlight the need to address inclusion and diversity for a policy that now currently mainly impoverishes, divides, stigmatizes, controls, and damages, and sometimes harms and kills. We must revalue people's lived experience and challenge the scientism of psychiatry and the psych system. That's the absolute aim of today's session. And each person will speak for a maximum of 6 minutes. Then we'll have some good time, I hope, for people to offer comments and questions as Jess has said. And kindly going first is Colin King, a mental health survivor. And since being diagnosed, he has been challenging inequality and social racialized injustices. Over to you, Colin. Thank you. You've got to put your sound on.
Yeah, so hopefully I've lost 10 minutes there trying to find my sound, so I can only talk for free. I'm just trying to share my screen at the moment. Just like to say good morning to everyone. Hopefully you can now see my PowerPoints that should come up. Can everybody see that?
Yep.
Yeah, good. So I'm privileged to be here, but I'm angry with despair and despondency and frustration about where we are in 2022. This picture epitomized for me the new economic policy slavery that's emerged in mental health, where the old white slave masters are replaced by new academic policy administrators who are imposing a system that's leading to a major violation of the Black experience, the Black lived experiences. These three people here are actually putting a system together that has not liberated Black people in mental health, it's actually oppressed them in the mental health system. So let's look at the data, which is really concerning. In 2022, somebody like me is more likely to be detained, to be given a community treatment order, and now we've been given this new type of slave option, an advanced choice document, which is really given the opportunity for policymakers to transfer funds to white organizations to produce new types of research, what are leading to a new type of racialized eugenic in mental health policies, which for me is alarming and concerning and needs to be addressed. But it has historical and cultural political implications. And the first part of this is looking at something called a depomania. Well, why is it policy is still dominated by a very US-centric white voice in methodology, research, and policy outcomes? And because of that, this is leading fundamentally and very concerningly to the denial of the Black experience. We do not have an Afro-centric diagnostic framework in current mental health practices. So what has happened in the transition from what I call the pre-production stage, the slave of slavery, has led to denial of liberalization in the co-production stage. So we are still experiencing in policy development and in practices, the colonization of whiteness and mental health as a system of psychosis. These pictures represent, for me, Cartwright's model of depomania. We are enslaved in the system through the community treatment order and the loss of economic and cultural power. But how has that emerged historically? I mean, what's been going on in the system that led to these devastating outcomes? And if you do an analysis, a critical analysis of the policy, which starts from 1851, we can actually analyze there's been a critical and concerning devastating failure of policy to translate into real outcomes for certain communities in terms of participation and outcomes. I'm not going to go through this legislation, but if we transfer the travel of the Black experience from Cartwright in 1851, we emerge in 2022, where we have a new white paper, a new National Health Service long-term plan, and the same types of outcomes. The two pictures are symbolic. This week, the Queen died and is lying in state. She represents a colonial past. But at the same time, Chris Cabba, who was murdered in Streatham, is not given the recognition of somebody who was murdered on the streets. Why is this taking place? And what do we need to change in terms of participation and in agending a new type of system that is representing perverse forms of madness and madness in really devastating outcomes? Just let me know how long I've got left. So I'm advocating.
Say a minute.
A minute. Oh, I'm not too bad. I'm advocating for an advanced choice for racial outcomes. I'm looking at theoretical changes that are based upon the epistemology of the lived experience, which is actually reflected in our legislation. The long-term plan says that we need to have parity with clinical experience. We need to inform the DSM as a power relationship, but also to inform a new policy outcome, we need an Afro-centric model that changed the diagnostic framework, a new anti-racist outcomes. I'm realizing that The way out for Black communities is a racialized advanced document that gives a passport to safety. And we can see that emergent in the Mental Health Use of Forces Act and the Mental Health Act. But we are in a critical position in the Black experience. Policy has killed us. Thank you.
Thank you very much, Colin. Let's move on, and it's so good to have the sweep of what you've had to say, to Sarah's contribution. Sarah, who identifies as an independent mental health and social care knowledge consultant, a survivor researcher, and an ex-academic. Over to you, Sarah, and thank you.
Thanks, Peter. I'm going to talk about a barrier to challenge, something that's come out of some work that I've done, research work. So in thinking about the topic for today, I reflected on some findings of a couple of user-led studies I've worked on. Both studies concerned issues of the abuse and harm of people who use mental health services. In both studies, we found that when people reported abuse and or harm to services, they were not often believed. And this was mainly because of their mental health status. And one participant said, my capacity to be a witness and give any kind of testimony in any way is contaminated. And borrowing from the survivor researcher and activist Vivian Lindo, who used the term, we called this psychiatric disqualification, meaning people being discredited or delegitimized because of their mental health status or their diagnostic label. And not being believed means not being seen as trustworthy. A person's experience, insight, knowledge, and perceptions are not to be trusted. And this relates directly, of course, to the idea of epistemic injustice, where some people's knowledge is given less credibility than others based on social and individual prejudice. And of course, the problem is further exacerbated if you take intersectionality and the compounding effects of other forms of marginalization and discrimination into account. So if people are constructed as untrustworthy in their individual encounters with mental health services, this could constitute a barrier to meaningful and influential user involvement in wider policy and provision. We know from many accounts over the years that mental health service users and survivors are often excluded from decision-making and are rarely in a position of power or control in involvement processes. Is this because we aren't always seen as trustworthy or credible? And is this because involvement often happens in psychiatric systems and cultures that position us as such? In a recent, and I'd say great paper, highly recommended, called Strengthening Review and Publication of Participatory Mental Health Research to Promote Empowerment and Prevent Co-optation, the members of the International Advancing User Survivor Capacity and Leadership in Research Collective argued that of research, publishing tokenistic research in which people with lived experience had minimal or no direct control over project decision-making or interpretation of findings, and describing it as participatory can be understood as reenacting what many people with lived experience have faced within the healthcare system. The systematic erasure of their or our own voices as sources of knowledge and meaning. And I'd say this is equally applicable to involvement in mental health policy and provision. Now, in individual involvement in frontline provision, we can see this problem manifesting for the peer support worker in a team of clinicians who said, I don't feel safe to talk about that stuff, their lived experience, because for me, the gaslighting, discriminatory conversations that follow would make me unable to come to work. There's a clear barrier here. Because of the oppressive psychiatric culture in which they're working, they don't feel safe to use their insight or experience in practice. In a reenactment of service user experiences in the mental health system, they risk being pathologized, distrusted, and even led to question their own perceptions. Now, at times I haven't felt confident, credible, or in control in involvement work. I've been reminded of my own experiences in the mental health system, and sometimes it's been a risky thing to do. So how do we address this challenge? Well, as we know from the history of involvement, there aren't any easy solutions. and it takes hard work on collective and individual levels. But we should continue to critically examine our experiences of psychiatric disqualification in the types of involvement that are overshadowed by psychiatric cultures in services and in society itself. In doing so, we can identify and address the different effects. But perhaps as a start, maybe we should consider what the authors of the paper on participatory research recommend. They say there must be space for perspectives that might cause discomfort and disagreement. Trusting relationships must be built with individuals and groups who have experienced intersectional layers of oppression and disempowerment. The goal of this process is not to achieve perfection, but to be transparent and honest about limitations and challenges, even as we continually try to strengthen methods and capacity. Thank you.
Thanks ever so much, Sarah. And a new word that doesn't feel at all like a jargon word, disqualification, which is a word we're used to, and I think which we can understand, and which is a bit chilling, I think. Thank you. Over now to Amander Wellings, is a neurodiverse service user and involvement in research, user involvement in research consultant. Over to you, Amanda, and thank you.
Hello, everybody. I'm going to start from the idea that I think that every bit of mental health provision should be evidence-led. So I'm going to talk a bit about public involvement in research, which is what I specialise in. I've been doing public involvement in research work for the last 20 years and trying to make public involvement in research really matter and really can. So I think public involvement in research is important from the early stages, having our own ideas and even carrying out our own research and being able to do that. I hate the term underserved communities. Are we underserved or are we seen as undeserved? That just seems so close that I often wonder. We need services that fit the needs and wishes of those who use them. Is there a pill for all ills? Do I want a pill? No, I myself want support. I'm a neurodiverse widow, but undiagnosed as neurodiverse, as many females go undiagnosed, and we wait on long waiting lists with no support whatsoever. I need help with everyday life chores. I need help to understand the nuances of human relationship. I used to self-medicate with alcohol. Now I work with others to include them in research as early as possible, hoping this will lead to change in services from the bottom up. Too long it has been authority telling us what we need. And I feel that we should be included by looking at different ways of working in partnerships with service users. Not just box ticking and doing what the researchers wanted to do anyway, but really acting on the wishes of those who use services. Always my neurodiverse brain thinks outside the box. There's never been a box big enough to hold it. It has a stream of consciousness thoughts and a lot of sort of saying without thinking sometimes, which gets me in trouble. But I use a lot of creative methods, especially creative writing. And I feel that we should get ideas straight away from people who use services, using plain English and using enjoyable ways of engaging with people. I've just done some creative workshops with sex workers who use drug and alcohol services. And the things that we actually produced from that, the poetry and the artwork, brought their ideas to life and brought them to a different audience that would normally see them. And what did the service users think of our evaluation that we did as part of the Public Health Initiative's Responsive Studies team from the National Institute of Health and Social Care Research? Well, we used a "you said we did" model. So we fed back and we showed them where actions had changed from what they had said, which I think is really important. I think this model would save resources. There'd be better health and social care targeted to those who use services, not just a pill for all ills, feeding the shareholders of Big Pharma. I myself am scared of services. Creativity comes from my neurodiversity. I don't want to be cured. I want to be helped. I want necessary adjustments to make daily living easier. I think modern society for the neurodiverse has too many stress factors, and I can't solve that, but I wish I could. And I think if research has the voice of the people using the services at its heart, I think we can change policy and practice that way. Even if it's only chipping away slowly, we're still changing piece of research by piece of research, and results reaching the right ears. Thank you very much.
Thank you, Amanda. And it does feel like consuming the elephant teaspoon by teaspoon, but I think we're game for the job. It's over next to Danny Taggart. Danny Taggart is academic director on the doctorate in clinical psychology program at the University of Essex. Thanks, Danny, over to you.
Thanks, Peter. Great to be following on from such interesting talks. I'm going to speak about something slightly different, but which I hope has resonance with Amanda, Colin and Sarah's talks in some ways. So as well as being a psychologist and a survivor of sexual violence, I worked at the Independent Inquiry into Child Sexual Abuse for 3 years from 2019 to 2022. I worked closely with the Victims and Survivors Consultative Panel, although I was employed as a psychologist in operational practice, helping to run various bits of the therapeutic services that the inquiry provided to survivors. I worked very closely with the Victims and Survivors Panel, and I had some reflections upon the types of participation that they engaged in and different models of engagement that inquiries have used internationally that may be helpful in conceptualizing and thinking about models of participation in mental health. So the Victims and Survivors Consultative Panel at ICSA, they were public appointments like the chair and panel, and they were out there right from the very beginning of the inquiry. And they were there to consult and advise on the needs of victims and survivors. There was a group of 8 of them who is, in addition to having expertise by virtue of their experience, often had many, many years, in some cases decades of experience in the field of sexual violence services, both as managers, as clinicians, and also as activists. And I think that's one of the things that often gets left off for those of us who have multiple forms of expertise, is that when we come in with a lived experience perspective, that's often all that people want from us. But we often have concurrent and parallel experiences as professionals, clinicians, carers, members of our community, and activists. So that's the first thing I wanted to note about the constituency of that group of people. The next thing that I wanted to mention was the impact that they had in designing the trauma-informed services that we developed as part of the inquiry. Some of the things that are really important in thinking about survivors and engaging in inquiries is reducing the risk of harm, reducing the risk of re-traumatization. There's a risk that engagement with the institution of the inquiry will somehow parallel the abusive relationship or being let down by other institutions, such as the police, such as the education system, religious orders. So there's a clear risk for people coming forward to an public inquiry like ours of being let down and re-traumatized, the same thing happening again. And I think that the Victims and Survivors Consultative Panel were absolutely imperative in helping us understand from a bottom-up way how to avoid doing that. So one of the big trendy things at the minute is trauma-informed care, which I think is a slightly overdetermined construct and often doesn't mean very much. It's a rebadging of kind of traditional service models. But I think that it has the potential to be transformative in a context like ICSA. What our research with people who came to the inquiry found very clearly was that the things that they often prioritized, the things that they noticed, the things that they found helpful, the things that they wanted us to have feedback as being good and helpful for them, were actually often environmental and interpersonal details that were part of what the Victims and Survivors Consultative Panel had prioritized for how we designed the system. So I think if it was me as a psychologist designing those models, I would have missed lots of the tiny detail that the victims and survivors panel picked up. So I hugely value the role that they played. However, in saying that, there are other models of participation in inquiries. So in Northern Ireland, the victims groups that set up around their historical institutional abuse inquiry, they didn't participate in the inquiry directly. They sat outside of it and lobbied it. And actually, at a policy level, they took it to the they took some of the findings from the inquiry to the High Court and had particularly issues around the minimum amount for redress. They actually had it overturned, and they managed to increase the level of compensation, the minimum level of compensation that survivors were able to apply for. So I think, very, very briefly, there are two models of participation that I've laid out in relation to inquiries. One is joining with the system and making changes that make a very significant difference in terms of the design and implementation of services. And another model, which is not completely distinct, but which does involve taking more of a distance perspective from the institution and instead focusing and prioritizing on lobbying and activism rather than being alongside. Now, I think that that's an oversimplification of how those two models worked, but nonetheless, as two examples, I think that both have a lot to recommend them. But I think there are attendant risks with doing either or. And so I just wanted to offer those up as two examples from the field of inquiries, which is a sort of developing area where survivors, it's now taken for granted that survivors will participate and will be consulted and will be involved in some way. But the form that that takes can take fairly radically different forms. Thank you.
Thank you, Danny. And I think that we may not realize what you've just said about two related forms, but we sometimes make our choices and work out which one might work for us. And it seems to me that hopefully there are enough of us to be able to take both approaches and get the benefits and deal with the disadvantages that each might have. Thanks. Over now to Rhea, and I won't do your name justice, so I'm going to only stick with your first name, is Senior Lecturer in Social Work and Social Care at the University of Sussex. And over to you, Rhea.
I will say my first name, thank you, Peter, and I will say my first name to start with, which fully is Reima Ana Maglajlic. And the reason why I mention it, it's relevant for the context where I come from, because it signifies that I come from different ethnic groups which were in conflict some 30 years ago, and which shaped significantly the experience and distress that I interact with the most, that people experience in former Yugoslavia, particularly in Bosnia and Herzegovina, where part of my heritage is from. I now live and work in the UK, and I come and speak to you from the borders. And I think that those contexts are important, and we can't do them just in 6 minutes, but I just want to acknowledge that we need to understand and kind of explore experiences much more widely. And the term Global South never sits well with me, not least because I was also labeled as not quite white, not quite European, and all kinds of things simply because of the nature of the events which happened in my neck of the woods and part of the world where I come from. And there are many experiences across the world that I think one thing, if we are to kind of explore different ways of understanding distress and different ways of shaping and reshaping our understanding and policies and practices, we really need to start learning much more from each other, and from an understanding that we have a lot to learn from each other across the world. History is also important, very important in this. Is the reason why I stand in this forum and in many others is my knowledge of English, because many of the people that I work with simply don't have it, despite my attempts to introduce them and encourage them to learn the language, simply because of what that opens to them to speak for their own experiences. And that can be problematic. History is also important, particularly of prior events. I think, having spent some 30 years around health and social care services in different capacities, mainly as a social worker, but also as an activist, it's important because there have been many, many good examples in the past, and somebody in the chat asked of a good example, and which is what I want to talk to very briefly. One of the examples of kind of influencing policy, which worked in Bosnia as a kind of post-war country where Reform of long stay hospitals was initiated through destruction of them, which is one way to start it, and with minimal loss of life, fortunately, associated with that. And development of community-based services coming not so much from the UK model, but learning from Italian model, which is very, very different and just kind of invokes a very different understanding of distress. And it led to development of community-based services. And after the war, the whole country has been highly decentralized with responsibility for health and social care. In some ways similar to UK, but in many, many different, much more politicized, is very, very different. And where, with support of now no longer existent organization, we had Pathways to Policy project implemented in Bosnia and in several other countries by an organization which was called Hamlet Trust, which organized and support survivor movement in Central and Eastern Europe and in former Soviet Union. And it's a great, great shame that that network and knowledge, vast knowledge, no longer exists in active life. And they helped and develop this project where through local policy involvement, there were forums created which built on experiential knowledge, which really needs to be the core of any such development, and where 2/3 of the panel were comprised of professionals which are relevant to them. And for most people, it was very much, as Sarah mentioned, violence and experiences of violence, which causes distress in most cases, poverty and addressing poverty, and lack of opportunities to earn funds for themselves, because all of the models now force people into employment, and that the function of any support is simply to lead back into employment. So that was where the focus was. So they invited local employment office, the local health and social care, but also housing ministry to kind of really invite them to engage in dialogue on those topics based on the findings they had on that locality. What were people's experiences and what were their priorities and needs to address? And focusing mainly, as I said, on poverty and employment opportunities. And people, they didn't go after the key people, they went for people who were interested to establish a relation with the local survivor organization, which comprised 1/3 of such panels locally. But people who were interested to engage, who mainly themselves had some experiential knowledge themselves of their family members who experienced distress, or themselves who have experienced distress, but in a way that enabled them to still keep their jobs. And this led to really fundamental changes on the local level through creation of employment opportunities and so forth, and really created a different context for survivor activism in this particular canton. Unfortunately, it doesn't translate to wins across the country. It doesn't scale up that easily, particularly because a lot of these innovations are project-based and short-term and very short-term funded, much like in the UK, that everything needs to be very successful in the shortest period of time, which in terms of creating lasting policy changes is vastly detrimental for health and well-being of everyone involved, and can't really vouch for successes, which are always expected. So we don't learn. We forget about such examples. We don't learn from them what made them work and why they may not have survived, or how they do survive kind of 10, 20 years after. This is a project which, for example, still reverberates some 15 years later. The core of all of this, I think, in the UK, much as in Bosnia, is intersection of poverty, violence, and distress, which gets kind of dissected across different separate policies, and health is seen as the most relevant answer to all, so that medical view of an understanding of such distress and poverty leads the way. One thing that I think we lack across the board is focus on basic income, which really was having benefits and having enough to live off and having a roof over your head was key and core for so much activism in survivor movement and mental health, where people opened up their home to kind of host day-to-day activities, to spend time to each other, and also to develop knowledge together. And I think I'm over the time, so I'm going to wrap it up. And the key question that you asked, Peter, was why Mat Studies is important. I'm always honored to be the only social worker on panels, and I always feel very, very privileged to have that voice. The reason why I feel that shaped me so fundamentally is because I learned from survivor knowledge, particularly from the late Professor David Brandon, and also we really need everything that we do, we really need to be doing it through enabling for experiential knowledge to lead the way and to work in partnership, which is a very easy to say, but a very messy process, which is probably requires a panel and several of them in its own right. I do apologize for running slightly over. Slavs are very notorious for it.
I'm not sure you actually did, to be honest. We're
just
on
a smidge.
time.
You're very kind.
We're on time. And that's been a theme of what people have said. There's the centrality of experiential knowledge, but also I think very briefly that the way that we cannot separate anything here from international developments, and the international is important, but not international in the way that the pressure for globalized mental health means international, i.e. a form of colonization. We have got some questions, and I hope, please, that the people who've come, and we're really grateful for your presence, will add some more. We've got a very specific one for Sarah. If she could put that citation she gave us into the chat or the Q&A. And then we've got one which I know that Ray has already begun to address, and I think this is a fair starter. We can get on to some other tough ones too. Does anyone have any examples they can share of an everyday success they've been involved in, even something minor? Who'd like to kick off with that, who hasn't referred to such a thing so far? Anybody?
I can put a link to Pathways to Policy documents, which are available. I'll put it in the chat. Just also to say, the prevalence of white British men and white, North American men in particular, and kind of Western European men across the globe, it dominates things. So, people from other parts of the world don't get asked to speak of their experiences, and even less so if they have had lived experience of distress. But it equally applies to professionals from those contexts. So it's kind of a global industry in more ways than one.
And you mentioned David Brandon, who would not fit into those categories, who's sadly no longer with us. And also you mentioned Hamlet Trust, and that reminded me of Peter Campbell, who was involved with Hamlet Trust, who sadly is also no longer with us, and we should remember Peter. Anybody want to come back on that question from Tom Todd?
Yeah, can I just say something, Peter,
Please,
which
Colin.
I think is important. I work with somebody by the name of Adibola Lewis, whose son was actually lost his life in Slam Resources in 2010. And it's up to her undying spirit and motivation that she actually challenged the legal system, the political system, and the legislative system, which led to a ground pound in legislation called the Mental Health Uses of Forces Act that came out this year. And that's what real political lived experience can actually do. It can change systems, it can change politics. And also the legislation that's now called Senni's Law makes us accountable for the safety of people in mental health systems and in police stations. So I think that's a revolutionary, one of the best things that's ever happened in modern mental health practice.
Thanks, Colin. And that really is important, and about acorns and giant trees, I think. Could you put any kind of a link, if possible, in the chat or the Q&A to guide people to find out a bit more about that, if that's possible for you, for which thanks. Anybody else want to come back to Tom?
Yeah, possibly. It's about little things, because I said I sort of chip away at bureaucracy and see what I can change from the inside. And I think it's being a review on some of the funding panels and things. So if you see a piece of research that comes up and you think, no, that's really not from the service user perspective, or that's really could harm people with autism because it's trying to cure them rather than help them, then I will actually put that on my response back to the funders. So I'm always sort of chipping away whenever I see anything that I don't feel is fair or any injustice. I will point it out to people, and the service users and people that I get involved in my group. I encourage them to be critical friends and to point out every elephant in the room. So I think by sort of having a voice at the right points in research, we can change research culture, albeit in sort of small ways, but we can make change.
Thank you, Amanda. I want to come on to the second question we've had from Talia Hazeldine. This reminds me also of an article in the current issue of Private Eye. It's a long question, but I hope people won't mind if I read it out. I'm here on behalf of women in the family court, and I'm keen to raise the issue of mass blanket diagnosis being carried out on behalf of the family courts by sometimes unregulated experts, and the life-altering damage these assessments are having on mothers and their children, resulting in almost all of them being separated immediately. We wish to know why misdiagnosis cannot be overturned, or why these diagnoses cannot be challenged even when they are entirely unevidenced by any behavioural or historical concerns. It's demographic that is completely silenced by the very secret fact of family court being somewhat a kangaroo closed court. I work almost exclusively on psych assessment expert reports in family court, and we cannot find a way to bring the huge number of women being declared mentally unfit to parent, who a majority live very ordinary, fully constructed, employed, ordinary family lives prior to being declared mentally unfit. All are victims of domestic abuse. And that seems to me a really central thing for us to discuss, which is giant in its implications and also specific. Would someone like to come back on that? I wonder, Rhea, if you'd like to as a social worker.
There is no easy answer to this, and I absolutely sign everything which is said in preparation to which Talia has highlighted here. And this is where the justice system, the health system, and social care system collude in very particular way, and everybody claims that that they don't have responsibility. There is a separate comment that somebody made about, do you know of any activism? Do you know of any organizations in the UK which kind of support people to do this? And it's really sad that, you know, compared to the very flourishing scene in the UK in terms of survivor activism in the 90s, that all of this has been eroded simply through lack of funding and lack of support that people experience. And it seems that after attempts to reform the system, that all that remains is this very rigid, punitive, discriminatory, frightening system in which people find themselves completely locked in. Education itself and preparation of professionals has been eroded. And while on one hand in social work, there is more involvement of people with lived experience, it really is quite creative how it's enacted by different organizations and different higher education institutions, as is opportunities to create knowledge. So I think that we really need to kind of find ways to start from activism, I think, first and foremost, because that base really, really needs to be there for everything else that we do. Parallel problem is that any attempts are, for a while I worked for an organization which supports legal advocacy and strategic litigation. And with the lack of free legal aid, people don't really have access to relevant information and representation, which is equally kind of, we are really living in this stripped down system, which because of all the events over the past couple of years, there's going to, and the impact this has had on budgets and so on, is going to get even further eroded. So activism feels like the only way to try and regain some of the spaces for that in a very volatile, punitive environment, and seeing how to share resources for free with each other and opportunities for that. Because somebody also asked about information being behind paywalls. That core of activism, there is now kind of open access, and more resources should be available free of charge, like the article which Sarah has shared. But unless we find a way to kind of reconnect the activism and the tissue of survivor movement in any country, in any context, it's going to be much more difficult, because unless we find spaces for each other, even if they are virtual spaces, to connect with each other and support each other, without that foundation, everything feels like theory and knowledge in vain. We need to kind of find ways to really be supportive of each other and create communities and families for ourselves, even when the real ones fail us. And for that to be kind of the soul of the movement for going forward. I apologize if I'm too vague or poetic in the wrong way.
I'll move this on. Thank you. Not at all. I've got a question here. Wendy Stainton Rogers. How do we change tertiary education so it doesn't collude with Psy as a dehumanizing force? Unless we introduce ideas like this, we will keep reproducing the horrid treatment. Would anyone like to come back on that, particularly someone who hasn't said anything yet since they spoke? For example, Sarah.
Yes, I was just mulling this over. I think in education and training, which I've been involved with some of it around social work and mental health nursing, I think one of the problems is that the curriculum is quite limited. Some work that I did a good while ago, we looked at the inclusion of LGBTQ experiences and perspectives in mental health and social work training. And often it's shunted off because there isn't enough room or time to talk about that. But that's absolutely fundamental to talk about equality and discrimination in social work and mental health nursing training. And of course, I would say absolutely vital to have people with lived experience of, yes, mental health problems, of the system, of the welfare system, of discrimination, marginalisation, teaching, but teaching on their own terms, designing courses, modules themselves with support from educators. So at the moment, a lot of what people learn is fairly reductionist. It needs to be expanded, but in the university context, there are problems and limitations with the curriculum and what people are expected to learn.
Thank you, Sarah. We've got loads of questions now, and I'm getting conscious of time. An interesting one from Matt Smith. Please, can we ask the panel what they feel, think, believe a panel should consist of? Who should be involved? That's an interesting question. I'm not sure if we're the right people to answer it, as we're all on the panel. So I'll move us on from that. There's another question here, which I'd like to take in relation to what Colin's been talking about, from Alison Faulkner. I'd like to understand a bit more about the model Colin was advocating that would act as a kind of freedom pass for racialized people, if there's time. Could you say some more about that, Colin? Would that be possible for you, as well as maybe guiding people to other resources?
Yeah, I mean, I need to contextualize. I'm not just a lived experience survivor. I used to be a social worker, mental health teacher and commissioner. And I see the power of giving knowledge back, but also civil rights back to people in the mental health system. And I also think the advanced choice document is actually deluding us to thinking that's going to avoid people being detained under the Mental Health Act, which should be a wider political choice about changing the structures and systems that lead to people having mental health problems. So the advanced choice document should be a politicized document that actually empowers people to change the way they've been treated in the English mental health system, in the educational system, in the childcare system, in all related to system. It's too narrow. And hopefully by doing that, we actually racialize changes in the way we were misdiagnosed by DSM, by ICD-10, by biomedical models, and the way that the mental health system is more about control and compliance in relation to the Black body. So you can see kind of like echoes of deprivation and slavery in mental health systems and how people are enslaved. And to empower people, you may have to use that language of the civil rights movement and apply it to other groups that are being similarly oppressed on the issues of class or race or sexuality.
Thank you. That brings us back to that point that was raised earlier, I think. Oh, that's a clumsy word by Rhea, intersectionality, which I do think is actually a very helpful idea, enabling us to try and think both of ourselves and of other people about the complexity of our identity, and being able to develop positive feelings about all those aspects. And as was it Sarah said, make sure that, no, it was maybe Danny, I can't remember, that we're not only called upon for some aspect of who we are, but for all our wide range of knowledge. It was Danny who said that. A comment here from Eamon Flynn, which I'll go through. Our family's children are distressed and scared of UK mental services, like Amanda. Why should we join in policy support or user support research if services are unsafe? Families, friends and carers I know are truly shocked by UK mental health services, the detention, violence on unsafe psychiatric wards, the coercion on heavily sedated drugs of our children and loved ones. The harm done by our own NHS to our family relationships is immense. What will this forum do to help families support their loved ones and keep them safe? Do the panel know of any family and carer activist support groups in the UK? Could we have some responses to that? That would be really good to hear, because I think that is where a lot of people, not unreasonably, are in terms of their feelings. Would either Amanda or Danny like to lead off on that?
I could just say, if anyone found some family and whatever support for these people like me who are struggling with their mental health but too scared to jump in. I mean, my brother actually died in a mental health institute. So, and my other brother has been treated badly with his social care and stuff recently. So, yeah, I sort of feel justified by being scared, but as well justified by looking for research when it seems as though it's discriminatory and somewhat dangerous to the people who have diagnosis of various things. So I'm sort of jumping in at that level, but I don't actually know of any organisations. But I'd love to find them to see if we can change it. So people don't wait until crisis before they have to get mental health care.
Thanks, Amanda. Danny, would you like to add anything?
Yeah, I think the question about whether people should participate or not, given that these systems are often very punishing and harmful to people, is a really well-made point. I think one of the dilemmas, I think, for people who bring their lived experience in is that they're doing so on behalf of other people who maybe they don't have the same perspective as, but also they're doing something on behalf of the group of people, the group of professionals who they're working with. And one of the things I used to say to colleagues who worked at the inquiry when they were dealing with survivors, I would say, well, we've all had difficult things in our lives, in our childhoods, different kinds of things. Imagine what it would be like for you if you brought the most painful, difficult aspect of your childhood experience into this conversation. Imagine how it would change the emotional tenor. Imagine how it would change how you responded to people who were talking to you. Imagine how it would change how you thought about the experience afterwards, how you dealt with some shame around kind of feeling like you'd overexposed yourself, for example. So I think that institutions that want to invite participation need to do a lot more work in order to make it safe for people. And in order to understand what it's like to do that very heavy lifting emotional labor in order to assist an organization who kind of wants to maintain the status quo. These are not radically changing systems. They tend to want a kind of homeostasis, a kind of status quo to stay the same. And so I think that at that contracting stage, it needs to be very clear what's possible to be changed, what's on the agenda, what's on the menu. And then people should be supported to make an informed choice about whether they want to take that risk or not.
Thank you, Danny. And you're right to say it's a risk. And I think looking back, I was very lucky that my first contact was not being approached or responding to an offer to get involved, but making contact. And we know that those organizations, our organizations, are having bigger and bigger struggles with a user-led organization, where you could get to know people, where you could have the confidence that they had got similar experiences to you, that they wouldn't ridicule or have other agendas that were undermining of you, and where what I always felt was you could start to be yourself again. And I think that the trouble is that that's always been a real route, I think, to empowerment, real empowerment, whether we're talking about the Black civil rights movement or second wave feminism or anything. but it is being made very, very difficult to happen nowadays by the cuts in resources available for it. And in the user-led organization I'm part of, Shaping Our Lives, we were just very lucky before we collapsed to get support from the big lottery, but that doesn't necessarily happen for everyone. From Neil Broche.
Peter, very quickly, can I just
Sorry, go
mention
on.
a national organisation called the United Family and Friends, which is a coalition of families across gender, race and sexuality about children that have died in the care system and in the mental health system. I'll put the link in, but they have a national march on March the 29th where they go to government and they're trying to hold the state to account for the abuse in our childcare school and the mental health system. So I'll put that in just to publicise that while I'm here.
Thanks very much for that, Colin. I was just going to come up with a comment question from Neil Broach. Hope I'm saying his name right. How can we challenge the epistemic injustice where patient reports of iatrogenic harm from psychiatric drugs are dismissed as delusional, etc., when financial interests and professional reputations are built around the use of those drugs? Would you like to say something in relation to that, Sarah?
So it's what can we do about it? Well, I suppose it's sort of something that Amanda said. The problem is so vast. It's kind of a chipping away on, I suppose, individual resistance, and then getting together as collectives and activists, as Reyes said, to challenge it, and also, you know, like you said, Peter, to come together to share our experiences. And not to be questioned or disqualified or ridiculed like we might be, or not believed within a sort of traditional service context. But I suppose it's acknowledging that goes on, that harm and damage goes on in the system, and a lot of the time that's to do with treatment, medication, incarceration. But it is definitely the job of activism to challenge that in many ways. So perhaps within the system, if that's where people feel they're most powerful to challenge it, I don't know how many would be, but and out with the system as well. So those are my kind of observations on that question, but it's a huge one.
Anybody like to add to that?
Sorry, Peter, I hope I'm not dominating this conversation, but just going to say a big thank you to Jasna and to Alison, because in this chat, if people read Senegalese law, statutory guidance, there's a clear framework to empower communities and users to actually challenge inappropriate use of medication and restraint and restrictive practices, which you know are being used as a matter of common practice now. And it's also, there are clear guidelines in Section 5 of how to challenge people in terms of care plans, trauma, unlawful discrimination. And I think this is where we have to empower our communities with the right type of legislation and advocacy where we can really make changes.
Thanks for adding that, and for the thanks that you offered. There's something really interesting here, I think, from Liam Kirk, which again I'll read out. In an attempt to address the institutional racism in mental health settings, I've followed the money by attending several clinical commissioning groups, CCGs, in the London area, and uniformly the individual with the purse strings responsible for funding NHS psychiatry is a white female GP in their 30s or 40s. Whenever I raise the issue of the disproportionate number of Black people being treated by NHS psychiatry, the response from the white female doctor is always the same. They walk away without saying a word, which in itself is a form of institutional racism. What can we do to address this process of brushing aside important questions on race and lack of transparency by the CCG commissioners? I don't doubt you'll have something to say, Colin, but anybody else first?
I think it goes deeper than that. I think it goes way back into who can afford to train to become a clinician, because a lot of the time it is people from a certain class and from a certain that have the money to go forward and do the training without bursaries and without support for people from from places where there isn't the backup of family money, then I don't think we'll change who becomes the clinicians. Unfortunately, because I mean, I've done a lot of interviewing for clinical psychology, so I see the sort of people that come up to actually study all the time, and it is a certain demographic. So yeah, I don't know what we do to fix that, because I'd like to see more people with lived experience actually come and become clinicians, but I think there's a lot of barriers to that happening.
Thank you. Danny, in your educational role, could you add anything to that?
I think it's a great point. My experience of supporting survivors, trauma survivors in their interactions with institutions that have been responsible for their mistreatment, often as children, is that what happens when you challenge an individual is they feel a high level of anxiety, and they have a professionalized, institutionalized response to that because they don't know what to say, because they don't feel enabled to be a human being and to actually speak to the person as a person. So what I've had repeated experiences of is supporting trauma survivors who find the process of attempting to get recognition for what's happened to them to be a dehumanizing experience because they're met with formalized institutional responses. So literally based on the conversations I've heard today, Colin's points in particular, I think that the way to go is to promote rights-based approaches to these things, because if it's based on a one-to-one interaction, I think more times than not, it's going to be disappointing and painful. And it pains me to say that because I don't think it has to be like that. But I think that it needs to be institutionalized the way that these organizations have to listen and are made to listen in particular forms, in particular ways.
And Colin, what about you?
Oh, it's quite sad and I get quite angry. It's very difficult to answer this question. I'm not going to be in an emotive level. I'm going to be kind of a pragmatist. That there is a strategy and framework called the Parent and Carers Race Equality Framework that came in on the white paper, and it's actually now saying that we have a statutory responsibility as from next year to hold people account for their cultural capability, the racist implications of their practices and policies. And I think it's really important that we actually publicize that, empower people to use that framework. This is held by Jackie Dye, who's leading some great work, and Black Fives as well. And it's a statutory responsibility as well. It's a competency issue as well. But deeper than that, there's the whole thing around Eurocentric pedagogy and how people are taught to assess and respond. There's a whole disrespect for the Black community, which is a kind of like a clinical sort of issue. I mean, there are clinical issues for clinicians that are incompetent of doing their practice that become racialized as well, that need to be challenged as well. But it goes back to the advanced choice document that we need to empower people, not just to change the system, but change the way they've been treated inside the system in that interactional level, and also to change the commissioning relationship as well. We're commissioning the same outcomes as we did 30 years ago, when Littlewood talked about cultural schizophrenia. So we do need a radical change. But as a pragmatic, I think we've got to use the Parent and Carers Race Equality Framework, which is a statutory obligation for people to change the racialized outcomes of their practice decisions.
And it's important, Colin, that reminder is made very clear, as you've just done. We need to come to the end of the questions and answers now. I'm sorry the time flies by. I hope people feel that they've had some good responses from our panel. It's now the time for each member of the panel to have a quick sum up, and I'm not sure how to do this. Perhaps it should be the people who went last go first and vice versa, if that's all right with everyone, or perhaps I'll just do it randomly. So could I start, as you're the first person I've looked at, with Reima? Thank you.
Thank you. Just to emphasize the last point, I think we are in a unique position if we focus on the UK alone. On one hand, there is a constant kind of stream of messages that there is a lack of good quality mental health support. That support itself is faulty and does not really address and support people appropriately. On the other hand, there is a lack of ability to build a better system. But where we need to start, I think, as much as Colin said, is a rights-based approach and activism to kind of rekindle the foundations of mutual support that people had, good, solid information, which is available free of charge, and all of the approaches, whether you're a professional or somebody with lived experience trying to ensure better support for yourself or your loved ones, to start with what are people's rights and using the tools which are available and which are statutory requirements, and building from that foundation onwards. I would also love to see more experiences of what has worked in the past and why it may have failed in the. That's something which maybe is something to explore going forward as people who are engaged in research on these issues too. I'll stop there.
That last point especially. Sarah.
Sorry, I'm scribbling away here. People are saying such incredible things. I've got this pad of paper.
There will be a recording, Sarah.
See, this is my kind of natural tendency to do this sort of thing. I think what I've really taken away from this is when people spoke about policy outcomes and thinking about what policies maybe we're permitted to participate in, drawing up or steering, and which ones we're kind of not as much. I think this comes back to one of my experiences and many people's experiences in mental health policy involvement, where we're reduced to our patienthood, where we're reduced to our experiences of treatment, of symptoms, the medicalised approach to conceiving us. When, as Rhea said, and as Colin said, we are impacted by policy outcomes. In things like, poverty, violence, racism, and yet we don't necessarily get a say in those types of policies. So we need to be involved across the board, not just in health and mental health policy or even social policy, but more broadly. So yeah, I've just been thinking and reflecting on how the issue of policy outcomes and how we might get involved in conceiving and creating policy ourselves.
Thanks, Sarah. Danny.
Thanks. So I think I've learned a lot from the conversation today and also from the questions people have been asking. I think the notion of psychiatric disqualification, which is something I hadn't heard before, albeit related to epistemic justice, which I'm more familiar with, is really helpful way to talk about what happens to people who have lived experience and they enter into these public institutions where very quickly, by virtue of a label that has been attached to them, often erroneously or inaccurately, they get treated differently and treated as less than. And one of the things that I guess I feel proud of, having worked at ICSA, is for all of the difficulties and limitations of that inquiry, they treated people primarily as citizens who had a legal statutory right to participate in a public inquiry. And then anything else, including their mental health state, came much later down the road. And I think that that's a precedent that should be promoted, really. I wanted to touch just briefly on the way that the kind of psychiatric disqualification creeps into other institutions of the state way beyond mental health services. And there's been particular focus today on the family court system and the way the psychiatric diagnosis is abused in a way as a way to mistreat mothers, fathers, and families, really, without really any scrutiny, without any transparency around that. And I think that that's massively problematic. And I also think that Sarah's point about the range of social policy that people should want to get involved in from a mental health activist, from a mental health experiential perspective is really important. I think there's a lot of talk about the recognition of mental illness as being legitimate, and we can have discussions about how much that's actually pervaded into different areas of society. But I would say it hasn't gone any further than recognition. There hasn't been any acknowledgement that that might involve social and economic changes, structural changes, and the Department of Work and Pensions in particular continue to stigmatize people with mental health problems who need social security in order to live with dignity, really. And so I agree that the kinds of spaces we're not getting invited into might be as important as the ones where we are able to have some influence.
Thanks, Danny. Amanda.
I just remember to unmute myself. Yeah, I think it's the fact that everything takes so long, and it is a case of getting together and trying to chip away, because I was shocked because I don't sort of look at all the clinical stuff, so I didn't realize that the term retarded is still used for learning disabled people in the diagnostic manuals. And I said to the clinician I was working with, I said, well, how can we change that? He said, well, it's a world thing. It could take years. So, and I'm going off to work with learning disabled people in the community now to get them involved in research if we get the funding to do the work that we're planning to do. And there was no way, because he said, oh, well, when we put the application in, we'll have to use the standard definition and the standard diagnostic manual. I said, no, there's no way I am calling my service users retarded. Thank you, end of discussion, was what I said. So I think it's things like that. We've just got to make people realise how what the psychiatric model is doing is making people feel uncomfortable, is branding people as not being able to do things. And I want to look at what people can do, not brand them for what they can't do. I'm sorry, but that, well, I don't have to be sorry. That's how I work.
Amanda, I'll have to move this on now to Colin. Sorry.
Yeah,
Colin.
cheers.
Yeah, I'll be very quick. I think my experience of being sectioning people and watching my son section, this is not a mental health system, this is a criminal justice system. And so we need to actually depoliticize some of the kind of barriers that face us and actually be more advocates for change. I really think that lived experience should be the central epistemological framework that dictates what is mental health. Mental disorder should never be in any act. That's a criminalization of our lived experience. We should set the agenda around the epistemology, the knowledge, the training, the commissioning. I'm really advocating the real importance that lived experience is paramount to a new change, a new policy change, an activation of equality across the colour line, and a new approach to mental health in every level of what we actually do.
I in my final words, and thank you, Colin, I would totally, absolutely agree with that last comment. Although when you said about it being a criminal justice system, I think the mental health system is a criminal injustice system with absolutely no accountability. But people have said things that are alarming. People have said things that are reassuring, like chipping away. It's helpful to see a comment from Keith Maloney that the law in Scotland is different. I'm not sure how fundamentally different, but that's going to be available in the chat afterwards when the recording is there. I do think for me a key concept today is chipping away. I also think that we have returned as we have to, and it's the global issue too, I think, to the issue of the appalling racism of the system here, as is the appalling racism of the system of globalized mental health that people like the World Health Organization and others want to impose on countries in the global south just as much as have failed in the global north. But we've both focused on the detail that matters, and we've focused on the big scenes that shape that detail. This is such an unfinished conversation, but I do think it's progressive because we've maybe come up with some of the old problems still being burning and problematic, but from a different perspective of new things happening. And I do think we are living in a time of human crisis in all sorts of ways. And I think that the serious difficulties affecting those of us experiencing distress are a magnification of that, and another reason why our maddening world needs to be corrected by all of us, but so many of us disempowered to have a chance to do that. In some sorts of ways, I think that people as members of movements like this, like those of survivors, are in that vanguard with that lived experience that people have talked about. So could I just thank everybody for joining in today, taking part. Thanks obviously especially to our panel and for the help we've had from the people at Policy Press. Thanks everybody. Thank you. Toodaloo for now.